Hello everyone and welcome to the third week of developmental psychology. This week's topic is physical development, birth, motor skills and growth. This week we will be discussing physical development from the moment a child is born until they reach adolescence. We will start with discussion about factors that can put children at risk for developmental problems. We will also see how a child acquires motor skills that allow them to manipulate objects and explore their environment. Finally, we will look at the physical changes during adolescence that prepare the body for reproduction and discuss how these changes can affect a person's self-image and personality. Most babies are born on time and healthy, which is wonderful. However, not all families are so fortunate. It's heartbreaking to know that about 3% of babies born in Canada each year, around 10,000 infants, have significant physical malformations. While some physical issues are immediately noticeable, other babies might be at risk for cognitive and social problems, as well as developmental delays. Psychologists emphasize the importance of early identification for these at-risk babies to provide timely support. Over the past few decades, numerous studies have tried to understand the factors that place infants in the highest risk categories. The most important factors are maternal and family characteristics, the physical compromise of the newborn, and the performance of newborn on behavior assessments. A baby's chances for development problems can often be predicted based on the family contents in which they are born. As we discussed last week, several maternal factors can increase the risk for the fetus. This includes the mother's use of drugs and alcohol, exposure to viral infections during pregnancy, smoking, and poor nutrition. Additionally, living in a poverty significantly raises the likelihood of various early threats to both maternal and child well-being. Preterm birth and low birth weight are nearly twice as common in low-income families compared to the general population, and inadequate parental care is almost 3 times more prevalent. It's estimated that 10% of babies in Canada are at risk due to poor health, nutritional status, and economic and social conditions of their mothers. Another sad statistic is that each year 45,000 pregnant women face significant challenges, including poverty, teenage pregnancy, social and geographic isolation, substance use, and family violence. To address these issues, the Government of Canada launched the Canada Prenatal Nutrition Program in partnership with community groups. This initiative aims to develop or enhance programs for vulnerable pregnant women, giving babies a healthier start in life. The program funds around 350 projects serving over 2,000 communities across Canada, and an extra 450 projects for Inuit and unreserved First Nation communities. Most of these projects offer prenatal and postnatal health promotion programs, referrals to community services, breastfeeding education and support, nutrition counseling, and prenatal vitamins. Each year, about 6% of babies born in Canada, around 18,000, have a low birth weight, which is below 2,500 grams. It's about 5.5 pounds. These low birth weight babies are at least 25 times more likely to die in the first months of life compared to babies with normal birth weight. While parents and other caregivers can usually manage temperature control and nutrition for these babies, breathing can be a significant challenge. Low birth weight babies often struggle with initiating or maintaining breathing. When a baby can breathe properly, oxygen doesn't reach their cells, causing cell death. Brain cells are particularly sensitive to oxygen shortages. Severe lack of oxygen, anoxia, can damage the brain area that control limb movement, leading to a condition known as cerebral palsy, which causes spastic type movements. Low birth weight babies fall into two distinct groups. The first group consists of babies born prematurely, before the 38-week gestation period. Preterm babies often have breathing problems, and in many cases, tiny blood vessels in the brain can burst, causing bleeding. Preterm infants usually have less mature brain patterns. They tend to be more disorganized and difficult to soothe. In the long term, these babies are likely to experience more frequent problems with growth and overall health. They are also at a significantly increased risk for cognitive and behavioral problems in later childhood and adolescence. The other group of low birth weight babies includes those whose fetal growth was delayed. These babies, known as small for gestation age (SGA), may be born at the expected gestational age of 9 months or earlier, making them both SGA and preterm. They fall into this category because their weight is among the bottom 10% for their gestation age. Several factors can increase the likelihood of delayed prenatal growth, including chromosomal abnormalities, infection, poor maternal nutrition, and maternal substance abuse. SGA babies are not easily aroused and have poor muscle tone, often appearing limp when held. Preterm SGA babies tend to perform more poorly on verbal IQ tests as preschoolers compared to preterm babies whose weight were appropriate for their ages. However, their eventual developmental outcomes heavily depend on the quality of their post-birth environment. A third clear sign of risk is poor performance on standard assessments. Babies born in Canada and the United States are almost always tested at birth. In 1953, Dr. Virginia Apgar introduced a test that allows obstetricians to objectively record the status of the newborn. This test has become the standard for baby's first assessment. The Apgar exam focuses on 5 vital functions of the newborn: heart rate, respiration, muscle tone, response to mildly painful stimuli, and skin color. Assessment occurs right after birth and 5 minutes after. On average, about 77% of newborns receive an Apgar score of 8 to 10. 17% received a score of 3 to 7, and 6% received a score of 0 to 2. Infants with scores in the 0 to 2 range have a neonatal mortality rate of 14%, while those with scores in the 8 to 10 have much lower mortality rate of only 0.13%. Several factors can lower the Apgar score, including maternal depression, anxiety, smoking, drinking, and labor medication. A low Apgar score below 6 is often caused by oxygen deprivation, hypoxic ischemic encephalopathy, a lack of oxygen to the baby's brain, and cerebral palsy, a condition affecting the baby's physical abilities. The Apgar exam assesses vital life processes and can be quickly administered, but the results provide only limited information. The Brazelton Neonatal Behavior Assessment Scale is the most comprehensive test for newborns. Its core premise is that although newborns may seem helpless, they have a set of organized behaviors for responding to both positive and negative stimuli. The exam includes items in 4 categories: attention and social responsiveness, muscle tone and physical movement, control of alertness, including habituation, irritability, and excitability, and physiological response to stress. A baby's performance on these measures provides a clear indication of their well-being and potential risks. The Brazel scale is an effective tool for assessing a baby's development in early stages. However, it's not a reliable indicator of long-term development beyond infancy, as there are currently no established norms for the NBS. The most accurate predictor of potential developmental challenges is the number of risk factors an infant is exposed to. Infants with a higher number of risk factors are more likely to experience difficulties. The environment in which at-risk babies are raised plays a crucial role in their development. One of the most important factors is the quality of the relationship between the parents and the baby. At-risk babies often bring unique challenges to this relationship. For example, a preterm baby might spend weeks in a special care hospital nursery, which limits the parent's chances to hold and cuddle their baby. Once home, these babies might have irritating cry, be hard to soothe, and have irregular sleep and wake patterns. They also tend to smile less during interaction and may avoid eye contact. Research has shown that parents often treat their preterm children differently, even after the initial differences between them and full-term babies have faded. This phenomenon, known as premature stereotyping, can create a negative cycle between parent and child. The resources available to the family are also a crucial factor. By the age of 2 or 3, children born prematurely into families with substantial financial resources are indistinguishable from those born at term.